you all into today's Vamos webinar series, broadcasted by Raj TV and supported by Healthcare. In our second episode of Vamos webinar, we are proud to have the living legend, Professor Dr. Moni Abraham Kuriakose. Before we start, let me have the privilege to introduce our speaker. Professor Moni did his Bachelor of Dental Surgery from Manipal University, India in 1983. He also successfully completed his MD from University of Bristol, UK at the year of 1992. He did his residency on general surgery and also on maxillofacial surgery, both from United Kingdom. He was a fellow of Roswell Park Cancer Institute and a board certified maxillofacial surgeon by American Board of Oral and Maxillofacial Surgery. He holds numerous professional memberships, including American Head and Neck Society, North American Skull Base Society, British Association of Oral and Maxillofacial Surgery, International Association of Oral and Maxillofacial Surgeons, and what not. Not only that, besides his beautiful surgery, he is the author of 4 volumes of book named Contemporary Oral Oncology. He also authored more than 150 peer-reviewed publications. Now, he is the director of Cochin Cancer Research Center, India, and serving as the president of International Association of Oral Oncology. Please welcome Professor Dr. Moni Abraham Kuriakose. Sir, welcome to our show. We are eagerly waiting for you, sir.
Thank you.
Sir, before you start, we are privileged to have our president of Bangladesh Association of Oral and Maxillofacial Surgeons, Professor Ruhul Amin. So I would like to ask Professor Ruhul Amin, sir, to say a few words before you start. Professor Ruhul Amin, President, Vamos.
Thank you, Rajiv. Assalamu alaikum and good evening to everyone. On behalf of Bangladesh Association of Oral and Maxillofacial Surgeons, extremely privileged to have today's speaker, Professor Dr. Moni Abraham Kuriakose, a world-renowned head, neck, and maxillofacial surgeon, director, Cochin Cancer Research Center, India, and president, International Association of Oral Oncology. He is an eminent speaker and a good friend and familiar all maxillofacial surgeons in Bangladesh. During the lecture, I hope we will have the opportunity to interact with speaker, view, and discuss. We will act as a landmark for the development of oral cancer early detection technology. Dr. Moni Abraham Kuriakose, we want to express our gratitude to you for being here and would like to request you to present your topic. Professor Dr. Moni Abraham Kuriakose, please start.
Yeah, thank you, sir. Thank you, Rahul. Dr. Rajiv, it's indeed an honor for me to participate in this webinar series. And we are living in a very challenging time, but challenging time brings a lot of opportunities. I've been to Dhaka many times. I have a lot of friends there, and I can see some of my friends in the webinar. Now, with this technology, I have the opportunity to talk to and see all of you directly by sitting from my home. So that is what the technology allows. And even in a challenging time, this kind of technology can be utilized. So I'm going to talk about another challenging situation we all face on a day-to-day basis, that is the oral cancer. So I'm going to talk about how technology can be used to bridge the gap or disparity gap when it comes to oral cancer. Now, oral cancer as a disease is a disease of disparity. This is a world map showing the incidence of oral cancer, like Bangladesh, India, and in fact, the entire Southeast Asia has the highest prevalence of oral cancer compared to the rest of the world. There are some exceptions like Brazil and and few France and a few other places have got similar type of incidents, but we have fairly high incidence, so there's a disparity when it comes to incidence of oral cancer. And when it comes to outcome also, there is a significant disparity. And this paper I have taken from comparing the outcome of oral cancer in India versus that of US. Here is the US database, and they compared the outcome of oral cancer in Mumbai. Mumbai, by the way, has the best cancer care facility in India compared to the SEER. I want you to focus only on the lower part of the table. That shows the overall outcome in India is about 20%, below that of US population. I'm sure same number holds true when it comes to Bangladesh too. But if you go into that paper in more detail, and they split the cancer outcome based on whether the tumor was diagnosed at a local regional disease, means after it spread to the lymph node, versus whether the cancer was diagnosed at an early stage. When it comes to local regional spread, that is N-positive disease, the outcome was significantly higher, almost 26% lower outcome in India compared to that of the US population. But if you look at the outcome in a localized disease, if the cancer was diagnosed at an early stage, the outcome is fairly comparable. This shows that with the available technology, available manpower, and the infrastructure in India, or for that matter in Bangladesh, we can get same outcome as that of New York, provided we diagnose cancer at an early stage. Now, the challenge is how to diagnose cancer at an early stage, okay? So how to bridge the disparity. And bridging the disparity comes from early detection. Now, there are different methods are available for early detection. I'm going to outline them, okay? One of the simplest method of diagnosing oral cancer is just by asking trained health workers to look inside the mouth. And this study is a fairly large study of almost 100,000 population from India. In one group, what they did was they asked the health workers to look at the patient on a 3-yearly interval. And the other group, they just waited for the patient to come to the hospital for treatment. And if you look at the outcome, the mortality rate in the control arm was 45 per lakh population. But in the intervention arm, the arm where they did that early detection, it was about 30 per 100,000. So almost like 15% improved the outcome just by getting some trained health workers to go and inspect the mouth. And they also went about and showed that this is a fairly cost-effective method. And they looked at what is the cost involved in saving the life. And they have shown that to save 1 year life saved cost only about 9,000 rupee. So fairly inexpensive method of saving the life as well as by early detection. Now, if we ask what happened to this study, this was done way back in 2003 or 4 and shows that it has not really reached the people. It remained as a project or remained as a paper. By the way, if you cannot hear us, please stop me and I will slow down and I will discuss.
No problem, sir.
Now, so that is the reason why for some reason, this kind of study has not reached the people. Now, if you look at, there are a lot of technology came up since then for detecting the oral cancer. We are all familiar with that. I have listed some of them. starting from simple technique like toluidine blue, various method of optical imaging like autofluorescence, induced fluorescence, optical coherence tomography, and so on. Then comes spectroscopy and molecular markers and so on. But there are a lot of technologies are out there. Now, if you look at the technology, I'm not talking purely about early detection, for that matter, any technology which has come for management of oral cavity cancer or head and neck cancer. If you go back in early part of the last century, chemoradiotherapy came up. Then towards 2000, we had cetuximab came up, and later robotic surgery, and even now we have the immunotherapy has come. All this technology, when it comes, there is an increased adaptation of the technology, and all that improve the outcome. There is no question about that. All this technology definitely improve the outcome. But the pace at which it is improving is in a very, very slow pace. If we continue to adopt the technology, definitely we will have improved outcome, but it is in a very slow pace. Now, the question is whether we can leapfrog, we can suddenly improve the outcome or not. That is extremely important when it comes to oral cavity cancer in Asia and Southeast Asian situation where this is one of the leading cancer. That is where I believe the technology is going to play a role. I mentioned to you that by showing that paper from Shankar Narayan's group carried out in India, that if you just train the health workers to look inside the mouth, that health worker can say that this is a cancer or this is a leukoplakia. Anybody listening to this talk can, just by looking this picture, we can say what is what. There is no need for any new technology. All what is required is just a pair of trained eyes. But the problem, as I mentioned, is that all this visualization procedure has not really reached the people where it matters. Some years back, there was a conference organized by WHO on M-Health or mobile health. And that was a large conference, not just cancer, but various aspects was discussed. By the way, in that conference, they discussed a project from Bangladesh called Mama Bangladesh. You're familiar with that. If not, I'll just summarize that. Bangladesh, like in India, has got a very high maternal mortality. So they used a small SMS program where the women gave the last menstrual period in the mobile phone, and then that connected to a server. Then the health worker contacted these women, and eventually it significantly improved the maternal mortality rate as well as immunization and various parameters. It made a huge difference. So at the end of this conference, WHO came up with the statement that this mobile technology, using this mobile phone technology, it has the potential to transform the face of health service across the globe. Now, one good thing about this mobile technology is that it penetrates almost every part of the world where it matters. If you look at this world map, if you look at the number of fixed telephone connection versus the mobile phone connection, sometime in 2000, the number of mobile phone connectivity increased more than the land phone. In fact, the village where I come from, there are more mobile phone than land phone connection. And this is the kind of transformation this technology can bring in. And this is a heat map of entire world showing in 2001, showing how many countries have got more mobile phone than land phone. The blue dot shows the area, the countries where there are more mobile phone compared to land phone connection. And if you look at the Bangladesh, look at that. Bangladesh in 2001 had more mobile phone than land phone. And definitely countries like Australia and Europe has got more mobile connectivity, and countries like India and Bangladesh has got the suddenly leapfrog, suddenly used this technology before they even got a land phone connectivity. So this technology has penetrated throughout the world and world where it matters. And if you go around Indian streets, we can see that adoption of something called Paytm, just using mobile phone, we can pay for your whatever you produce you buy, so without actually paying the money. So it's actually penetrated throughout the society. So the future of healthcare is going to be mobile first. Now, coming back to that oral cavity cancer early detection, what this mobile health technology allows is to connect specialists. I mentioned that a specialist like us listening to this talk can, just by looking the mouth, we can diagnose cancer. But unfortunately, we do not go to the villages where this actual problem happens. This mobile technology has the potential to connect the people in the village to the specialist. Now, if you look at all that technology which I listed in some of the slides earlier of oral cavity cancer early diagnosis, from just a visual examination to the light-based type of adjuncts like autofluorescence, vital stain, or even cytology, all these are images. Whether you look or take a fluorescence or a cytology, all this can be considered as images. If they are images, you can digitize them. If you digitize, then you can move that image from the point of care to a specialist sitting in a center like Dhaka Dental College or a maxillofacial surgeon's clinic, where the specialist has got the opportunity to look at the images. Now, we can even go further. There are the artificial intelligence available, as well as several other machine learning algorithms available, which can even bypass the specialist so that he can make a diagnosis even without a specialist intervention. That is the power of mobile health. Now, we ask the question whether this, our eye, the specialist eye, can be replaced with the phone of a mobile phone by a project we call it as a OngoGrid. So this project was carried out with a group of summer students from MIT way back in 2007, and my colleague Praveen Bairo published that in 2016. I will not go into details of this project, but just want to summarize by showing one slide. Okay, what this slide does is you can see that this woman taking a picture of somebody's mouth, and this lady can go to the village or to their patient's or subject's home, wherever that may be, and then take that image. That image can be sent to the remote place, and in this the study, the remote place was the cancer center located in Bangalore, and this village was in Bijapur. Similarly, we connected about 7 different primary health centers throughout the state of Karnataka, and then we use this app to find out whether they have high-risk factors like chewing alcohol and everything. And then they took the images, and multiple images were taken, and this image can be zoomed or rotated to find out exactly what the lesion is. And this image can be interpreted by the specialist. And this is the one slide I was referring, one slide summarizing the result. So this was a study of almost like 3,400 subjects. 1,400 patients were screened by dentists, and about 2,000 were screened by the health workers. And the dentist identified 106 suspicious cancer. Almost the same number could be remotely confirmed by specialists. But when it comes to health workers, the number was not quite accurate, because the suspected lesion was 130, but the actual diagnosis was only 23. So there was some problem with healthcare workers. But at least in a dental practitioner's hand, this technology appears to have worked. So then what we did was this technology was taken up as an app carried out by the Oral and Maxillofacial Association of India, as well as FHNO, the Head and Neck Oncology Association, by an app called Expertise. And this essentially connected the various dentists and ENT specialists in the community. And this app was used to connect, to refer the patient, as well as take images as refer the patients. So I will just quickly go through what the steps involved in this app. So as soon as a patient comes to the dental clinic, they ask some questions whether they have high-risk features or not, and then they take some images. This image will be sent to the specialist to interpret, and then along with that, they can mark where exactly the image was taken. And then the specialist, when they look at it, there will be number of cases will be there. The specialist needs to review. They can press one after another and say that, oh, this is a traumatic ulcer, not a cancer, or this is a suspicious one. Or we can say, make a call, and we can ask the patient to be sent to the nearest place for a biopsy. And not only that, we can track where exactly the image was taken. Like a GPRS system, these are all the places this particular health workers have gone and visited different, each dot is a image or patient this health worker screened, and then we can track them where exactly this image was taken. This is important because a lot of Indian villages do not have a named address or street number. So this kind of GPRS tagging help us to trace the patient back to where they actually belongs, and then we can take the remedial action. I can just show you some of the pictures and some of the issues. For example, this is one of the images which was sent. This striations from tobacco chewing. And sometimes we get lesions such as this one, significant tobacco stain. We don't know exactly what is happening underneath this stain. Similarly, there is another two lesions. These are a homogeneous leukoplakia. This is a homogeneous leukoplakia with a red patch here. So we cannot really say that, oh, this patient needs to go from that remote village to a hospital for a biopsy, because if you ask the patient to go for a biopsy, it's unlikely that they go for biopsy. So unless there is a fairly high degree of accuracy that this needs a biopsy. So that is where the adjuncts come to play a role. Adjuncts like autofluorescence and so on. Now, when it comes to autofluorescence, we are familiar with that. every tissue in our body fluoresces at a specific wavelength. When it comes to oral cavity, there are two molecules are used to integrate oral cavity lesion: collagen, which fluoresces at about 400, and NADH, which fluoresces about 350. So these two wavelengths are used to test whether this lesion is suspicious or not. And the endoscope is one of the devices currently being used. So this kind of image can be taken. If there's a loss of fluorescence, that means there is no collagen signal. That suggests that this lesion may be abnormal, that needs a biopsy. Now the question is how we can take it up into the community level. So this is an ongoing project we have taken up with the University of Arizona. This is a project supported by National Health Institute of Health in US. So in this, this is almost like a mobile phone with a probe which can take both the white light as well as autofluorescent image. So both the image can be taken simultaneously, and then the specialist looking from the center can and suggest this needs a biopsy or not. So I will not go into details of that. Again, autofluorescence, as you all know, has got a lot of false positivity. So it's not specific for cancer. That's one of the problems. Now the question is whether we can identify some kind of fluorescent probe which can tag to specifically to cancerous tissue or not. So this project is a project in which we use a lectin. Lectin binds to abnormal fluorescent protein, and then we first did a test using ex vivo sample. Sample was taken and lectin was applied, and then see whether there's a fluorescence or not. And this was found to be effective. Then after that, what we did was we did a clinical trial where we applied that lectin with the fluorescent probe in the oral cavity. I just want to show you some of the images. This is a verrucous carcinoma. You can see that lesion you can see here, and then definitely it can be, it fluoresces intensely. But look at this lesion. This lesion you cannot see by naked eye, but if you apply this lectin with the fluorescent, it lights up. That shows that this has got much better predictive applicability compared to white light. But look at this benign ulcer, where from a camera phone, we might mistake this as a cancer or some other malignant lesion, but lack of fluorescence suggests that this is just a benign type of lesion. So
sir, if you permit me, can I have a question, sir?
Sure, sir. Sure, yes.
Sir, this use of lectin, is it the study done in India, sir, or
Yeah.
somewhere else?
Yeah, this study, entire study I'm talking about is done in India. So this lectin study was done with in collaboration with the University of Michigan. So they provided the lectin, and then we did the ex vivo. They did for the esophageal cancer, and then we brought into India to study oral cavity cancer, because esophageal cancer is not very common in India. So we used that first in a biopsy samples in India, and then we did a clinical trial using this. But all the study was done in India.
It seems quite promising, sir.
It
seems quite promising, sir. So is it expensive, sir, or not that much expensive?
Oh, it's very,
I mean, the cost of lectin, sir. Yeah,
it's extremely inexpensive. Lectin is it's a plant-based dye. It's almost like, you know, if you it's a very inexpensive. It doesn't cost maybe Indian rupee cost about 5 rupee or something.
Oh, that's great.
It's very inexpensive.
Okay, sir.
But when if you do an R&D project and you give to a company makes a lot of money. So they will market it at higher price.
Yeah.
But when developed, it is at a very inexpensive.
Okay, thank you, sir. Please carry on, sir.
So in this study, this was a small study, 55 patients. If you look at the sensitivity was 100%, specificity about 80% compared to benign malignant cases. But pre-malignant cases, if you look at the sensitivity is poor. Okay, so some of the pre-malignant lesion, it did not have the accurate sensitivity. There was some problem. But maybe as an initial screening, this may be useful, but there was some problem. But this is just a first study. Okay.
Okay.
Now, let us say that we look at that patient. We did this study in a village. And you say that this lectin-induced fluorescent is positive. Then you tell the patient that, oh, you have to go to Bangalore or Dhaka for biopsy. This is what we do. We send the patient from village. You ask them to do a biopsy in the village, in a specialist center to biopsy. Now, most of the patients in India, they don't go. The reason is that, for them, nobody wants to diagnose themselves with cancer. And most of the time, these lesions are not painful or not symptomatic. And also, if they travel, cause they lose one day's ages. So it's unlikely that if you ask them to go to a specialist center for biopsy, they don't go for biopsy. Okay. So if we can't do biopsy, whether we can do cytology or not, almost like a cervical cancer diagnosis. So we ask the question whether we can replace a biopsy with a cytology or not. Okay. And if we can do by cytology, then rather than sending the slide to a specialist center, can we just take an image of this cytology and send the image sent to the remote pathologist to make a diagnosis or not? And this project again was done in India with a group by Siemens, one of the the company. Okay, we did this project with them. So what we did was this study had 82 patients. Some of them were cancer and some of them are pre-cancer lesion. I want you to look at this table here. And when it comes to cancer versus low-grade dysplasia, sensitivity was pretty high, about 90. And specificity was slightly low, about 70%. Accuracy was 88%. But with cytology, we could not diagnose low-grade versus high-grade dysplastic lesion. Very poor, 25% sensitivity, and specificity was about 73%. Accuracy was 37%. So even though,
sir,
yeah.
One more question, sir.
Yeah.
I mean, if I'm not wrong, that means we can say, we have a better sensitivity saying cancer, but not about the grade.
That's correct.
But we can say that it's a cancer tissue.
Yeah, cancer can be diagnosed by cytology, but not pre-cancer. Okay, but most of the time what we are trying to do is we are trying to identify the lesion even before cancer. But definitely for cancer, this can be used. Now the question is, so this can be used for cancer. So we ask the question, rather than directly looking by microscope, whether we can send the image. So this is a concept. So normally what we do, we take the image, the pathologist look at the microscope. So instead of that, we use this almost like a palm top, okay? And then took the images and then send the images to the specialist to look under the microscope. This project was carried out with the support of Siemens as well as UC Berkeley in the US. And Berkeley we approached because Berkeley developed this technology in Africa to diagnose some of the parasitic infection. So parasitic infection is very common in Africa. So they can do this, the drop liquid imaging for this parasitic infection. So this is how UCUs. So we asked the question whether we can do that for cytology or not. This is not a new thing, but we are adopting the technology for some of the problem we are facing. So this is the study. So there was 2 pathologists involved. Okay, every slide was looked at by 2 pathologists. And if you look at this pathologist can diagnose cancer versus pre-cancer lesion. Okay, but this pathologist, look at that. This lady could not diagnose any of the pre-cancer lesion. So there is a lot of inter-observer variation. That is one of the problems when it comes to cytology. But cancer, both the pathologists could diagnose. Okay, so here is the direct microscopy. If you look at the accuracy is 63%. Telecytology, by sending that image, the accuracy was exactly same. There was no significant difference, showing that whether you send the image or directly look, you get almost exactly same diagnosis. So as I said, this is good for cancer. So this project is currently being taken up in a community level that's going on. At the same time, we want to improve upon it. Okay. Now, as I mentioned, most of these images are cytologies are images, and images. There are a lot of inter-observer variability, which I showed you in the earlier slide. For example, this slide. See, this pathologist can make a diagnosis of pre-cancer. This pathologist cannot make the pre-cancer diagnosis. So we ask a question, if the human cannot make the call, whether we can bring in artificial intelligence to improve the diagnosis or not, okay? So this is an ongoing project we are doing along with the Indian Institute of Science in Bangalore. Small study, 60 patients. So what this study does is they've taken different cytology images. Each cell, each of the neoplastic or pre-neoplastic cell, it is rotated in 8 degrees, 8 different angulations, and changed into different intensity. And then we ask the question, there's an algorithm called convoluted neural network. This is almost exactly same algorithm the Google use. For example, if I type in Google and type the word cytology, within few seconds, fraction of a second, it will come up with the most accurate reference, what you're looking for. Because there are millions and millions or trillions of cytology reference will be there in the Google database, but it needs to, within fraction of seconds, it needs to identify most accurate cytology related question. So that goes through an algorithm called convoluted neural network. I do not understand that. That is done by this the AI people. So we asked the question whether this can be used for differentiating leukoplegia, high grade versus low grade leukoplegia, as well as cancer. So as I said, each of the images were rotated in different angles, different density was given. And if you look at the cancer diagnosis, it did not really improve. But if you look at the high grade dysplasia, if you look at the previous, it was about 20 odd percent, but the machine, it could improve to about 70%. Accuracy was increased to about 80%. So, but this is a very smaller subset, only about 60 patients were used, and about 100, almost 1 lakh images were used for training. Now imagine if the millions and millions of data sets were used for training, this accuracy, I'm pretty confident we can improve. But there are some issues. It could not differentiate a low grade versus high grade dysplasia. That's a problem. And we are working on it. The lectin, which I mentioned at the beginning, we are trying to bring in molecular cytology into this cytology, and then using AI for interpretation. So, ladies and gentlemen, to summarize what I spoke about, oral cancer is definitely a problem of our country, okay? And one way we can bridge that, improve the outcome and bridge the disparity is bringing technology, and technology is cheap. Mobile phone is penetrated throughout the villages. We need to adopt the technology, and as we are talking using Zoom, although we had some technical problem at the beginning, when it really worked very well. We could talk, and then this kind of technology can be implemented for early detection. And this technology, I must tell you that we should not be a slave to the technology. We should be master of technology. Technology should be there to help us out. And technology should never be too pricey. It should not be too expensive. If the technology our village people cannot afford, it is not appropriate technology. For example, in a village setting, or we need just a white light images. In a dental practitioner setting, we may have to bring in autofluorescent. When it comes to a more center, we may need lectin-based technology, or even cytology, or even molecular cytology I was talking about can be brought in. So all this technology with a different complexity can be brought in at different levels of healthcare delivery. So that's the summary of my talk, and I just want to thank the people who have done the work. Even though I now work in Cochin, in Kerala, the entire work which I discussed was carried out in my previous job in Bangalore. This is my research group. Most of the work was led by Dr. Amrita Suresh, and this is my clinical group, okay? And this is the community people. KL is a dental school where I work, and Dr. Praveen leads that activity. All the community work was carried out by Praveen Bairur. And one person which is common in all the images is this person called Samsam. Samsam is here in dental college. Samsam is in the clinical Swartz lab. And he is a oral medicine specialist doing a PhD with us. And a lot of work I mentioned was carried out by him as part of his PhD project. Once again, really thank you for inviting me, and my apologies for the issues we had at the beginning with the beginning of the Zoom lecture. Thank you very much.
Thank you, sir. It's always a pleasure to have you, sir, among us. And sir, please, sir, Ruhul Amin, sir, you are saying something, sir. Please carry on, sir.
Okay. You can question session, and our discussion is now learners audience. Learners viewers can speak, say the question about these topics. I invite our learner audience.
Thank you, sir.
Please go on.
Sir, as always, your presentation was brilliant, and it was very easy to understand. And you have so many things new for us, especially the fluorescence thing. I think we can also think about it to use in Bangladesh as well, because we have a lot of mobile users, and also the idea you shared to get the connectivity with the specialist and the doctors working in periphery might be a very good tool to help the cancer patients. So, sir, we are very happy that we have Professor Motiur Rahman Mullah with us. He was the immediate past president of BAMOS. I would like to call Mullah sir to say a few words for the audience and for Moni sir.
Thank you, Rajiv. Thank you.
Thank you, Professor Moni Abraham, for the wonderful presentation. Can you hear me, please?
Sir, we can hear you, sir.
Yes,
Okay.
sir. Yes, sir.
And
Yes, sir.
really, it was a learning session today, we learned a few new things about the early detection, especially in our environment like Bangladesh, India, or something where there is a poverty and economic crisis and a lot of difficulties. So I don't have much interaction with Professor Moni, I know, because I left Dhaka Dental College 2000 and then ultimately went to Bangabandhu Sheikh Medical University. So I don't have much interaction with you. Anyway, I am also, so I was initially the once president of BAMOS, and now the young generation is there. Now I have another organization, as I told you, possibly is in Bangladesh Oral Cancer Society, where I am the president here. So BAMOS and or any other organization like Oral Cancer Society are really trying to help this our community, poor community. See, as you can see, possibly we have when you have visited Dhaka Dental College, there are so many patients, oral cancer patients waiting in a long queue, and the OT date is possibly after 2-3 weeks, and that's why Dr. Ismatara Haidar is struggling to manage those patients, and majority of the patients are having an advanced stage. So it means that we cannot really cope with this huge pool of treatment patient. So what is important is your early detection and awareness so that we can really control the incidence of the cancer. That's why you have rightfully mentioned today is a new technology where also we can possibly share in future, like the mobile phone, where you have nicely described that how you can take the image or teach the younger doctor. That is the two eyes, you see, to experience how to understand what is the basic difference between a normal ulcer or a specific ulcer, precancer ulcer, or a cancer ulcer. And somebody, health worker can train, take the photograph and send it to appropriate center, ultimately to have an early diagnosis. And again, you talk about the new thing that is immunofluorescence, where you have used possibly the lectin, the new agent. I've never heard about it because we normally used to use Toluidine blue for easy and very cheap one. But as you said, lectin is also very cheap. So that can be, if it's possible, introduced in Bangladesh as well. So there's two things I like to say. And also you talk about cytology. That's also very important that we are sending our patient mostly for biopsy, because normally we say cytology report could be sometimes very confusing and false negative or false positive sometimes happen. So at least if you take the image that you have devised, to take the image of the cytology and then you send it easily to an histopathologist. So before sending as a whole, the whole tissue and everything to the patient, to the histopathologist, is a simple way to get the understanding of about the precancer lesion or cancer. So I have really learned about this, and thank you very much once again, Moni Abraham. I look forward to work together. And I know that you are a good friend of Bangladesh and Helping Dental College, and we also look forward to work together with also all other community, especially of the Bangladesh Oral Cancer Society as well. So thank you once again, and thank you, Bamos, Mr. Rajib, is a wonderful guy. He has organized this, and also our president and Lita, everybody is. Mohideen is here, so Mahmoud is here. So all people are very, they love this subject and love to learn things from you. And so we look forward really. We are improving. We need your support. Thank you very much.
Thank you, sir. Appreciate for your comment.
Thank you, sir, for being here with us. We also have so many eminent maxillofacial surgeons of the country today with us. We have Major General Professor Ghulam Mohideen Chaudhary, sir, who is now leading as the Consultant Dental Surgeon General in the Director General of Medical Services in Bangladesh Army. He is leading the dental faculty of Bangladesh Army, sir. So I would like to invite Major General Professor Ghulam Mohideen, sir, to say a few words about today's discussion.
Thank you very much, Dr. Nawajesh, and welcome, Professor Dr. Moni Abraham, And thanks a lot for your nice presentation. We have gathered much more knowledge out of your lecture and different ideas. And I also give my thanks for all the participants, my teacher, Professor Mutiran Mullah, and my other colleagues also, and the BAMOS, thanks to Professor Ruhul Amin for arranging this nice lecture. Actually, I am with my professor the same way. Actually, there are so many patients in our country. So many patients every day. They are coming and they are reporting to us, and sometimes they are diagnosed from the even from the remote areas or from the district levels. They are diagnosed, but our limitation is there in some areas for the Florence system or the other detection system. Maximum time we use this either scrapping method or the for the confirmation by the biopsy system. But sometimes patient they try to avoid this biopsy for the fear. So it is better if we can take the system other with this the agents, chemical agents, or the scrapping system also. But one thing it is nice that yes, from the use of the mobile phone, it is a new idea. Although sometimes we are practicing in individual level that when a patient is getting, especially in this COVID situation, they are asking their talking that we have got or I have got developed an ulcer in my mouth or tongue in area. What can I do? And many of us, we advise them, please take a photograph with a good light and send it to us so that we can have an idea at first. But there is no system that I'm sending this slide for much more advanced detection. But we are practicing this thing, but not in an like an apps or like in a group or in a cohesive manner. Actually, I think we can develop a system so that we all can work together for the detection, for the false positive, false negative, and the early detection, and teaching the juniors so that they can get the idea of these lesions by seeing. We are seeing this lesion that yes, it is the most probably it is a positive lesion, and these are the negative lesions. If they can develop this idea, and then patient can be much more benefited out of that. So I hope this lecture will help us to work further in this field, and we can help our patients in a better way. And thank you very much again for coming in this lecture session and helping us. Thank you, Professor Muni Abraham. Thank you.
Thank you, Major General. Thank you.
Thank you, sir. So as you said, the cytology can be a very good alternative instead of biopsy. So I think that may create a huge prospect for patients to be helped by the doctors of Bangladesh as well. So you are a very good friend of Bangladesh. You are having visited almost all the centers in Bangladesh. We are very privileged to have the head of the Department of Oral and Maxillofacial Surgery of Dhaka Dental College, Professor Ismatara Haidar Lita ma'am with us. And I would like to ask Lita ma'am to say a few words with Moni sir.
Thank you. Thank you, Dr. Hi. Thank you, Dr. Moni Abraham. I actually mentioned at the end, 2017, you visited our dental college and you did cadaver dissection and also live surgery. And most of the maxillofacial surgeons, I know that they attend your program and they're very much happy and learn many things from you. And I think most of the younger surgeons are waiting to talk with you many things because you are very good in ITF clearance and other things. So I think we could not waste our time because Moti Rahman Mullah sir and our Ghulam Muhyiddin Chaudhary sir already talk about what we want to do. But one important thing is that we want to serve the patient. If we can do the early diagnosis, then prognosis is good. Without local regional, you have mentioned that prognosis is good, the survival rate is good. So what we achieve, we want to do the early diagnosis and we want to serve the patient in early cases without any local regional research or local regional or anything. So by in our government now give emphasis on the non-communicable disease. So we can do some work with the non-communicable disease, just like screening, and we have much more community healthcare. So in the village there are community clinic and much more health worker. So by mobile health, that is M-Health, we can take photograph and send the patient to the dentist, local dentist, and then local dentist took something and they gradually transfer the patient to higher center. It is one of the important things. So I think it is very important lecture for us and also for our every young energetic surgeon. So it is very important, and I think many surgeon or many young maxillofacial surgeon are waiting to talking. So I, on behalf of BAMOS, I would like to thanks again for coming in this webinar and take excellent presentation of oral cancer early detection and technology to bridge the gap. So we are waiting for discussion, open discussion, all of our young surgeon. Yeah. Thank you, Moni Abraham, again. And again, you will come visit Bangladesh quickly after over the pandemic situation.
Thank you, ma'am.
Certainly, Dr. Ismat.
Thank you, ma'am. Thank you for your nice words. There is one more thing I should mention. Madam will lead us the BAMOS as a next president as well.
Oh,
so,
congratulations, madam.
Advance congratulations, ma'am.
Thank
I
you
mean,
very much.
I can see another maxillofacial surgeon who is a very great surgeon and a very great inspiration for a lot of lady surgeons in Bangladesh, Dr. Tarin Rahman. I would like to ask Dr. Tarin Rahman to say a few words for us, ma'am, please.
Thank you. Thank you, Dr. Rajiv. Thank you, Dr. Ruhul Amin, for giving me the opportunity to do a few words to this renowned professor. Thank you, Dr. Moni Abraham, Professor Moni Abraham, for your nice presentation. Actually, it was very useful for us. Actually, we realize, we can understand the importance of your technology, what you have seen and have shown to us, and you have adopted, already adopted in your country. In this pandemic situation, we realize how much it is important, how much we can use it. So what you have shown to us is very much necessary, actually, also in this pandemic situation. Like your country, our country is burdened with cancer patients, and it has a big impact, a great impact on our financial condition also. As they come very late stage. So we should give concentration on early detection and also prevention and awareness building also. In this, you have shown the technology also. Rita madam also mentioned that we need the trained and skilled personnel from the very primary level and secondary level also. So we have to train our young generation health worker to use this technology and and make awareness how to detect the cancer. And also in this pandemic situation, we feel that the follow-up of the patient also, the patient who have already been treated by us, is very, will become very much difficult to give follow-up of the patient. Already 4 months has gone, also we cannot, we are not being able to give follow-up of the patient. So we have an opportunity to also in the sector of giving follow-up, as most of the patients of our country are poor, develop cancer, and they lost whenever they have been treated here, but they become lost. Most of them are very much reluctant to come back to, for follow-up. So we in future we have to do something with this technology to give follow-up of the patient. So your presentation taught us many things and opened our eyes, many sector of our treatment. Thank you. Thank you.
Thank you,
Thank
madam.
you, Dr. Tarin. Really appreciate your comment. And the post-COVID area time, the healthcare on the whole will change. Definitely, there'll be transformation in healthcare, and the way we're going to look after the patient going to be different. So the earlier we adopt technology, the better.
Yeah, thank you, sir. That was an important point indeed, because I think after the pandemic is over, our whole scenario will be changed. How now we dealing the patient, and later on it will be changed for sure. And might be mobile play a very big role afterwards. We have with us Professor Dr. Nasiruddin, who is leading the Oral and Maxillofacial Surgery Department in Shohid Sohrawardi Medical College, Dental Unit. And as we taught earlier, that we cannot save every patient we deal. But as you said, Moni sir, that if we can detect earlier, we may save so many lives. As you showed in your first slide, that there are almost 15% reduction if we can intervene early. So I would like to ask Professor Dr. Nasiruddin to say a few words about today's presentation, and if you have any comments or suggestions, sir. Sir, we can't hear you. Probably. I can't hear. Moni sir, can you hear Nasir sir?
No. I cannot hear.
Me too.
So you can go other person.
I'll
So
speak
you
once
can
again.
go, you can shift it.
Okay, ma'am.
Other person.
Nasir sir, we are coming back to you. We can't hear you, though we can see your video. I'll come back to you, sir, once again. We have Harun sir with us from Dhaka Dental College. I would like to ask Harun sir to say a few words and any questions if you have for Moni sir. Probably he is also facing difficulty with some network issues. I can see our ma'am from BSMMU. She is my teacher, my mentor, and my idol. I would like to request Mahmouda Akhtar madam to say a few words with Moni sir. Madam, yes.
Yes.
We can hear you, ma'am.
Good evening. Thank you, Modi sir, for sharing your knowledge and time with us. Really, it will help our patients because we learn a lot of things from you. And simultaneously, I must thank BAMOS and the young organizer, those who are organizing such a wonderful and time-demanding program. And you are, Monisa, you are a researcher of coaching centers. So, as for example, lectin, fluorescent image, these things are sticking in our mind, which we get from your lecture. And we also hope that we'll try this for our poor patients also. And a few days before, I send a mail to share your opinion, suggestion, guidelines, any direction, even your smile. Obviously, if you want to share with our poor patients to boost up them or to do something for them. And you replied, thank you very much, sir. And soon I will send you the details. So in this event, I have a lot of questions to ask you, but there are lots of surgeons also waiting to talk to you. I have one question, sir. One, not only questions, just your opinion. Usually we get the histopathological report, which reveals that it is well differentiated, fully differentiated. That is Broders classification. That is grade 1, 2, 3, 4. But it's my opinion that the depth of invasion, pattern of invasion, the response of neurovascular bundle or lympho connective tissue structure also important to assess the condition of the cancer or aggressiveness of the cancer, which is mentioned in NRX classification. So, sir, what is your opinion regarding this point? Is it NRX is better than Broders, or what do you think?
Madam, thank you very much for asking that question. It's a very important question. There was a time when we were depending only on the Broders classification. That's a grade of differentiation. But now things have changed. That is only how much keratinization happens, how much atypia happens. But a lot of other features have come up. You mentioned about depth. Along with that, the pattern of invasion is very important. And also perineural and lymphovascular and lymphocytic infiltration. Putting all together this Brandon Weiss grading system, that is much more closer to clinical prognosis than just differentiation alone. Now, this is an important, but we have not really applied that into clinical practice yet. Now, the question comes, let us say if you have a close margin, what to do for that, okay? And if a close margin with a high-grade feature, like pattern of invasion, depth is high, then we might recommend the patient for adjuvant treatment. So all this subtle variation we need to bring in for an individual patient's treatment decision. But Broader alone doesn't really help. But all the other features which you mentioned definitely going to play a part.
Sir, thank you, sir.
Thank you, sir.
Can I ask another question?
Sure, ma'am.
Okay. No, so there are lots of surgeons waiting. So thank you. I will ask sir later on.
Thank you, ma'am. Actually, we have so many people asking to talk to Monisa. Probably they are overwhelmed to see you, sir. I can see Dr. Nadimul Hassan with us. He is currently working as the associate professor and head maxillary surgical oncology department of National Institute of Cancer Research and Hospital. I'm sure today's lecture is very important to him as well. So, sir, if you comment or if you would like to say something to Monisa.
Thank you, Dr. Rajiv. Moni Abraham sir's lecture is very, very important for us. As in my institute, like others, we are facing 70 to 80% advanced cases. So if these cases diagnosed earlier, we can save some source of life here. So the technology have mentioned, the mobile phone and the fluorescent technology and cytology, just we are looking for this to transform this to our country. And I earnestly request after the end of the pandemic, sir, if you consider us to give us this technology so that we can start something. Thank you very much.
Oh, definitely, you have all my support. We are all together in this game.
Thank you, sir.
So
Thank
thank
you
you,
very
sir,
much.
for your nice gesture. And I think, sir, you can help us with the app as well. Probably you already know the limitations and the plus points of the app.
Yeah,
So if you can help us with that, probably that will help our doctors and the patients as well.
I will. Yeah.
Thank you, sir. We are going back to Professor Dr. Nasiruddin. Sir, can you hear me, sir?
Yes, can you hear me now?
Yes, sir. Now we can hear you, sir. Sir, right now we can't hear you again.
Okay, can you hear me now?
Yes, sir. Though there is some echo, sir, but we can hear you, sir.
Thank you, Dr. Moni Abram, sir, and also thanks to Bamos for arranging such a good program. And the lecture is very important because it gives us a good idea about diagnostic way and also some ways studying cytology and biopsy. What are the how we will diagnose easily squamous cell carcinoma malignancy. And one thing I want to say about the diagnosis from the peripheral area. If we can develop a software like India, then we can easily take information from peripheral area to our centers. They can take photograph and send the picture of the lesion to any center. It will help us by from our dental surgeons also. They can connect with the magnificent surgeons in any center. And Moni Abram sir is always a good friend of us and also a good teacher for our magnificent surgery and also for oral skin surgery. He taught us in a good way, and we are very grateful to him. I have one question about nivolumab. Is it working in your country postoperatively or preoperatively? Because I have one doubt. After surgery, the lesion is already removed, and is it possible for nivolumab to be targeted into the tumor? Is it possible?
Yeah, thank you for asking the question, sir. Currently, there are only two indications for nivolumab. Locally recurrent tumor which are resistant to standard chemotherapy, or metastatic disease which has gone to bone or lungs. No indication for as an adjuvant treatment. So if the tumor has recurred loco-regionally and you have given cisplatin and the tumor has not responded, then you can give nivolumab. Second is that if the metastatic disease, you can give nivolumab or pembrolizumab. But having said that, the overall response rate is only about 3 months. There is a 3 months improved survival. But there is significant variation from patient to patient. Some of the patient can have a dramatic response that can be very durable. So it is, and it's a very, very expensive drug. So we use very carefully in only in selected situation.
Some cases, if it is inoperable case, is it possible, is it used in your country in case of inoperable cases?
No, sir. The response rate of a standard cisplatin-based chemotherapy is far better than nivolumab. So all the inoperable case gives standard cisplatin almost 60% response will be there. Then after that, if the response doesn't, if they relapse, then you bring in nivolumab, not as a first line treatment.
Okay, thank you. Thank you, sir.
Thank you, sir. That was a interesting information for us. As you said, that there are so many people working in the periphery, and they are carrying our oral and maxillofacial surgery, not only in Dhaka, to the other parts as well. We have Dr. Habibul Hassan Marshall with us. He is doing the maxillofacial surgery in Rajshahi division, and he is currently leading the OMS department in dental unit Rajshahi Medical College. I would like to connect Habibul Hassan sir to say a few words with Moni sir. How do you feel in periphery?
Okay. Thank you. Thank you, Professor Moni Abraham Kuriakos sir, for your nice presentation. Today, we are delighted to see you in such a bad condition of the world. And your presentation is excellent as usual. And I thank the moderator for connecting me and giving me the chance to say something. Actually, I am working in Rajshahi, the northern part of Bangladesh. Rajshahi is known as oral cancer prone zone of Bangladesh. Our experience is that we are getting so many oral cancer patients which is in advanced stage. That's why, as we know, the surgical outcome is better in case of early cancer. So, always need that the cancer should be early detected, early detection should be done. Moni Abraham Kuriakos sir nicely discussed of the matter. How can we detect oral earlier and thereby can save life? And I think that we can apply this technology, this new technology, to our center also. So this kind of presentation, I learned a lot from such presentation, and that this will not only inspire us, but it will create a hope, new hope for us. Thank you.
Thank you, sir, for connecting with us. I would like to, there are so many questions among the young surgeons as well, sir. If you allow me, I would like to connect some of them. They have so many things to say, not only about the early detection, also about the surgeries you do usually.
Yes,
we have Dr. Uday Goswami from Dhaka Medical College with us. I would like to ask Dr. Uday Goswami. He is a promising maxillofacial surgeon working in the Dhaka Dental College. Please, you can say what you want to ask Moni sir.
Thank you, Dr. Rajiv, and thank you, our favorite Professor Moni Abraham sir. Can you hear me, sir?
Yes, Uday, how are you?
Fine, sir. Again, thank you, sir, for your innovative information, and I think will be highly helpful after hearing your presentation. I have a query, sir. Now you are the president of International Academy of Oral Oncology. Is it possible to run a screening procedure in Bangladesh under any international organization like International Association, Academy of Oral Oncology or International Association of Oral and Maxillofacial Surgery? Is it possible in Bangladesh to run any screening procedure?
Yeah, thank you, Uday, for asking the question. See, what is important is that we all take ownership. Okay, we all take the responsibility to run the program. But the technical help, for example, the app which we are talking about, that is free. We can just give the app to you guys and can use it. But running and the guidelines, which patient needs to be treated in what way and everything, the guideline which we can provide. For example, Indian government has got the professional organization like us formed a national cancer grid guideline. Now each of the state developed its own guideline how to adopt this guideline. Okay, so say for example, what can be done in Dhaka may be different from northern part of Bangladesh. So that kind of slight variation we have to decide. Okay. But the overall guidelines we can, the IAOO or AOMSI, one of the organization can provide the overall guideline. Adoption of the guideline, we all have to do it locally. And then technology like the app, definitely we can provide. There's no issue with that. Only thing, you just have to have a server in your facility for taking it up.
Thank you, sir. We do need some logistic and technological support.
Yeah, definitely. I can definitely. You can count on me on that.
Okay, sir. Thank you again, sir. See you again.
Thank you, Uday. Sir, we have another young and energetic maxillofacial surgeon with us, Dr. Abdullah Masood. He is waiting from the very beginning to talk with you, sir. Please, Dr. Abdullah Masood.
Thank you, Mr. Rajiv. Can you hear me?
Yes, we can hear you.
Yes.
I express my gratitude to everybody, especially Moni sir. Actually, I want to talk every day, all the day when Moni sir is in the screen. So it is our pleasure that we have learned from Moni sir. So actually, you have said lots of logistics support and technique. Which technique you say that it is easier and cheaper for a low socioeconomic country like us? So that is my query. And another question from the young surgeon, I think, in case of ITF involvement, when we not to operate, that is, you please clear us which ITF involvement we do the operation and which is not operable. Thank you, sir. Thank you very much.
Okay, thanks, Dr. Abdullah. So the coming to the technology, what the technology we need to develop is cytology. So if we can develop a technology almost similar to pap smear in cervical cancer. See, cervical cancer incidence is coming down. Early detection is happening, cure rate is improving. But oral cavity, so far we could not develop cytology like cervical cancer. So that is one area. There's a lot of work to be done because the morphology, the atypia of the cell, the shape and the nuclear size and all that is not as easy as in cervical cancer. So we need some kind of molecular cytology to be developed. So that is one area we need to work on. Okay.
But AI is promising, isn't it, sir? I mean,
yeah,
artificial intelligence is showing some promises.
Absolutely. Artificial intelligence is going to come. So that is something which we all have to work at it. Our small study of 80 patients showed a significant improvement. That was a very small study. We recently got a grant from Gates Foundation, $1 million for cytology project. So that I'm sure within about 3 years, we will crack it. Okay. So that's something which we are working on. Similarly, all of us needs to work. Now, second question is about the infratemporal fossa involvement, buccal mucosa with infratemporal fossa involvement, when we should not operate, okay? There are two situations we should not operate. Overall, we should not operate if we are going to get a positive margin. So we study the scan carefully, and if there is a chance that we are going to get positive margin, we should never operate. If you operate and if you get a positive margin, it is, as I always say, it's almost like done a biopsy. It doesn't really help no one. Okay, chemo RT, you can do whatever you want, but doesn't help. Okay. Now the question is how I can, before going to starting the operation, how I will know that whether I'm going to get a positive margin or not. Okay. So I look at two areas where there is issue. I look at the posterior wall of the maxilla and see whether the tumor or the enhancement has reached the inferior orbital fissure. Because, you know, the posterior superior alveolar nerve branch of the maxillary nerve gets get out of the inferior orbital fissure area. Okay. So if there's a tumor or enhancement at the inferior orbital fissure, whatever we do, we don't get negative margin. So that's one area. Second area is that if the tumor is tracked along the inferior alveolar nerve to the foramen ovale, okay, and that you don't normally, when we do the CT scan, difficult to find. But if you suspect, let's say that there's a perineural, there's numbness of the lip here, okay, and then the scan showed that the tumor has gone above that notch, sigmoid notch, okay, and there's numbness here, then I suspect that there may be tumor tracking along the mandibular nerve, okay. In that situation, I will do an MRI scan. If the MRI scan showed enhancement of the nerve, I will not operate. So these are the two situations I don't operate. All the other situations I operate.
Thank you, sir. Thank you very much.
Thank you, sir. It's a very good information for us. I used to say to my students and to my colleagues, one thing, I had a discussion with you, sir, long back. You said one thing, still I remember, and I quote everywhere whenever I can. That is, you said that the stage 4 cancer patients, what we follow is basically the textbooks written by the Westerners who doesn't do stage 4 cancer operations. But we do a lot of it, but we are lacking of documentation. So we are not evidence-based. We have so many experiences, but those are not documented. So you said once that we should do the guidelines, especially for stage 4, tumors, because we do most, and that you should tell it to everyone. That I am following, sir. And I believe that if we can document those cases, definitely the guideline should be followed, should be done by the doctor continent, especially in India, Bangladesh, and in our surroundings.
Rajiv, one good example is stomach cancer. Okay.
Yes, sir.
Stomach cancer was managed totally differently in Japan versus the West. Okay.
Yes, sir.
So Japanese, by perseverance, showed that stomach cancer can be operated, and the outcome was very good. And they showed to the world that there is a way to manage the stomach cancer. Similarly, oral cavity, particularly advanced stage 4, we manage much more than others. But the problem what we have is we don't document, as you said, and we don't publish. The Japanese are very good. They publish again and again by multiple groups, and now the staging is staged. Similarly, we have to publish. We have to record and publish.
Thank you, sir, once again for saying that to me. I remember still, and I will always remember it. And you are doing the task, we know. You have already a book published, and a lot of articles is there, especially about the ITF. Now, previously we thought that it was inoperable, but you showed us that no, not in all cases. You can go for operation and you can save lives. Thanks once again, sir, for here with us. And there are a lot of learnings basically we have from you, and I'm sure we will get more from you. We are in the end of the show. I would like to ask once again our President, BAMOS, Professor Dr. Mohammad Ruhul Amin sir, to say a few words for the audience and for Moni sir as well.
Thank you, Rajiv. I again, during this ordinance conference, I hope this opportunity to interact speaker and our viewer and discuss this better. I wish this discussion is wonderful. Stay in webinar. Everybody enjoy this program. BAMOS webinar series. Our renowned maxillofacial surgeon, international surgeon, Professor Dr. Moni Abraham. His topic: oral cancer early detection, technology to bridge disparity gap. I thanks again Dr. Moni Abraham and our learners, audience, and viewers who are seeing that program. And thank you again. Thank you all.
Thank you, friends. Good night.
Thank you very much.
Thank you, sir.
Thank you. Thank you.
Thank you, sir, for here with us.
You are watching রাজ টিভি, জাগরণে বাংলাদেশ। প্লিজ সাবস্ক্রাইব